All right, so we'll get started. So hi everyone, welcome to our Thursday morning concussion support group meeting. My name is Tiffany and my pronouns are she, her. We are a student-run support group based out of Montreal, Quebec in Canada that provides support to those recovering from concussions and other brain injuries. We've been around for several years and began hosting Zoom meetings in the March of 2020. Please be patient as we continue to grow and adjust things, and please don't hesitate to reach out or fill out our feedback form with any feedback or concerns you may have. A friendly reminder that we are not a therapy group, nor are we medical professionals, and this is not a replacement for either. We are only a support group that is run by students who are also concussion survivors. We can only speak from our experiences and things we've learned. Anything you hear during meetings is the opinion of the person sharing and does not necessarily reflect the beliefs of the Concussion Legacy Foundation or Concussion Montreal. Absolutely no harassment or discrimination will be tolerated in this group, including but not limited to race, religion, gender, or sexual identity. If you have violated this rule, you will be asked to leave. If you're feeling uncomfortable by anyone in the group but can't explain why, please reach out and let me know, or fill out the feedback form after the meeting. All issues will be addressed immediately. So just a reminder that we will be recording. The only thing that is recorded is the speaker's share and nothing else. So today our speaker is Dr. Alain Ptito. He is a professor of neurology and neurosurgery at McGill University and a medical scientist at the Research Institute of the MUHC. Dr. Ptito has worked as a neuropsychologist at the Montreal Neurological Institute and Hospital since 1983, and he is now the director of the psychology department at the MUHC and a recognized expert on traumatic brain injuries. His research program involves the investigation of the mechanisms involved in cerebral reorganization and plasticity in patient populations. For the past several years, he has been using functional magnetic resonance imaging, or fMRI, to investigate motor recovery in stroke and the neural substrates of residual vision in the blind visual field following hemispherectomy. He is a member of the Order of Psychologists of the Province of Quebec and of the Société des experts en évaluation médico-légale du Québec. So thank you for joining us today, Doctor, and you can start sharing.
Thank you. It's a pleasure to be here. Just a correction. I've retired from the directorship of the Department of Psychology at the MUHC. So now I'm doing most of my work on traumatic brain injury, especially on a private basis, as well as continuing my research at the Neuro and at the Montreal General Hospital. So I thought for today I would just give you a few things here and there about what I've been doing and some facts about traumatic brain injury. I'll try to go more or less quickly so to allow you to ask questions if you have any. So let's start. So usually when we talk about the incidence rate of head trauma, we talk of up to 600 cases per 100,000 in the population, and that's huge compared to well-known diseases such as Parkinson's, which is 20 per 100,000, or multiple sclerosis, which is 3 per 100,000, and yet we hear a lot about these neurological disorders, but the head trauma is way up there. Most of head traumas are mild. It's a misnomer because mild implies that everybody recovers and it's not really something serious. And but yet there are a good number of people that sustain this kind of mild traumatic brain injury and have lingering symptoms. The primary causes, usually it's motor vehicle accidents, and then falls, especially in the elderly, and then there's assaults and also sports. I've concentrated most of my research on sports injuries, although we did do a good number of studies with motor vehicle accidents. The reason for sports is that it's usually there's no litigation. So the person, in fact, has a tendency to lie because the athlete loves his sport and wants to go back to play. So they have a tendency to minimize the severity of their symptoms so they can go back to what they love to do. So we were interested in looking at those aspects because there's no litigation involved, and then we can study more clearly what's going on there. Oops. I like to look at head injury to classify them on kind of a spectrum or a continuum, going from concussion to mild, to moderate, and to severe. And usually they're divided up according to the Glasgow Coma Scale score. So when we talk about concussion, in fact, we're talking about somebody that didn't lose consciousness and that is dazed or dinged or stunned. So there's an alteration in the mental state, but the person hasn't lost consciousness as they do, for instance, in mild, where the Glasgow Coma Scale score can be 13 to 15 out of 15, and there can be a loss of consciousness of less than 20 minutes. And then essentially there are no abnormal neurological signs. And then, of course, you have the moderate and the severe, which we won't talk about, but only to say that it's based also on the score of on the Glasgow Coma Scale. And you have the kind of questions that are asked here on these slides in order to arrive to a score out of 15. There are quite a number of misconceptions about mild traumatic brain injury. Most of the time, we still hear this today, that the symptoms are transient and that they'll resolve in all of the cases. That's not necessarily true. The symptoms may take time to evolve, so they're not immediate. And they may, often we hear of people that felt okay, and then the next day they're feeling headaches and they're feeling all kinds of different symptoms that they didn't have initially. And this can be problematic in terms of insurance, because most of the time insurance companies, they will say, well, you didn't lose consciousness and they didn't have any symptoms, so the person is okay. And so that brings my next point, that brain injury is always associated with loss of consciousness, and that's not true. So you may have no loss of consciousness, and yet you may present all kinds of different symptoms typical of a traumatic brain injury. The symptoms, well, most of you probably know the symptoms. There's a temporary confusion and disorientation, amnesia of the event, headaches, nausea, vomiting. You can have all of these, some of these. And then later on, the symptoms can be divided up, and they can last weeks to even months. They can be divided up into somatic symptoms. So we're talking about headaches that are persistent, dizziness, vertigo, fatigue, insomnia, visual complaints. You can have some of these, you can have all of these. Mood is an important one. Anxiety, depression, irritability. Often we see, and I'll show you some of this data for depression. And then there are cognitive deficits such as slower thinking process, a slower processing speed, poor attention, and impaired memory. And again, this may vary from one individual to another. So the clinical picture that we have of people that have persistent post-concussive symptoms is that the neurological exam is normal. If you do a CT or MRI, the conventional type of MRI, in 99.9% of cases, it will be normal. And then there's no obvious cognitive deficits, but the person still keeps on complaining about some symptoms. And so there has been a tendency to conclude that the symptoms are probably psychological in nature and nothing is happening in the brain. And I have this is most of my career in this field of over 30 years. I've been trying to demonstrate that in fact there is something happening to the brain, and that is responsible for these symptoms. What is the evidence? Well, first of all, there is the possibility of diffuse axonal injury. So that's widespread damage to the white matter of the brains, the connectivity between regions of the brain, and these are very difficult to detect on conventional MRI, and that's why most of the time the MRI will come out normal, will be interpreted as normal. But as you can see, you can let me see. Okay, as you can see here, you can have an impact here, and you can have deficit or alterations or bleeding in the central regions of the brain. So one hit can cause the central regions of the brain and some bleeding there, and so this is to keep in mind. What happens, the mechanism is that the brain is holding on to the brainstem, and there's the brain, when it gets a hit, can move inside the skull and not only hit the sides of the skull, but also scrape by the bottom regions of the brain. And this is what we see in acceleration and deceleration. And you can see in the red here the different areas that can be affected when a violent impact happens. So, and this is an example here of a coup and the diffuse axonal injury. The coup and contre-coup, you can get a hit here and have more damage on the other side because the brain is moving inside the skull and hitting the hard bony surface. Or you can have, as I showed before, diffuse axonal injury, where you have damage in the central, more central regions of the brain. What happens at the cellular level and at the axonal level, we can have these kinds of tears or that are here. And what happens is that the structure itself is not affected, but it may be the connectivity between structures that is affected. So the axon can be torn or ripped like this here. So you can have that's the normal axon, and then you have a shearing that happens, a torsion, and then it can tear, and then post-traumatically you have these regions that are still disconnected. And this may be the reason why there are lingering symptoms. Also, there are neurochemical changes that happen when there's a concussion. I'm not going to go into detail about this, but the message is that when there's a concussion, there's a release of transmitters, and there's an alteration of oxygen metabolism and of glucose supply, and the organism is in a metabolic crisis, and it's shown here, and it may take several days for the equilibrium to return, and so that's why we see individual differences. Some people recuperate quickly, other people recuperate more slowly, and you can see it. It can vary up to days and more. These neurochemical changes. Okay. So, but there are, of course, evidence. There is evidence suggesting an organic basis to post-concussive symptoms. There are neuropsychological studies. Usually, we're talking about deficits in frontal lobe functioning. So, mental flexibility, meaning ability to adapt to the changes in the environment, planning, organizing. We see that people have trouble with these when they have post-concussive symptoms, attentional difficulties, and information processing that is slowed. So these are most of the things that we observe with a neuropsychological evaluation in people that have persistent post-concussive symptoms. There are also electrophysiological studies, so changes in EEG patterns, and we see them, excuse me, and we see them happening with EEG. So there are certain waves, electrical waves that are affected and that take time to come back. And usually in symptomatic athletes, the studies have been done with them, there is a particular component called the P300 that is affected, and it's been seen over and over again. So we tested varsity athletes before the season begins, hockey and football players at McGill, and we tested them after the concussion, and we also followed them 3 months later, and we looked at them, but with functional MRI. So functional MRI, we use a task that we know is sensitive to particular regions in the brain. So in this case, we use the working memory task. And this working memory task is particularly sensitive to functioning of the frontal part of the brain, a region called the dorsolateral prefrontal cortex. So we submitted 100 subjects, normal subjects, to these tasks in the MRI machine. What happens in the MRI? The region of the brain that is the most active will demand more blood and more oxygenation. And that way we see an increase of activation in the particular regions that are involved in carrying out the task. So here we see with these subjects, what we see is, I'll point out these particular regions here, and or here it's circled, and that's the dorsolateral prefrontal cortex. And we see that in normal subjects, there's a high activation there, and it's called the bold signal change. Okay, blood oxygen level dependent change, just for your information. And so what we see, the gray zone is the bold signal change in the dorsolateral prefrontal cortex. And each black dot is an athlete. And you can see that most of the athletes that were concussed have blood oxygen level dependent changes lower, so it's called a hypoactivation in the region compared to what we would see in the control subjects. So most of the subjects show hypoactivations in the regions when they're carrying out this working memory task. I won't go into details about that. So we can compare the bold signal changes for each group according to the severity of the symptoms. And what we see is the control subjects show pretty nice activations in the regions here. And as the symptom severity increases, the activations go down and lower. So the more severe, the less activation. We also do use a navigation task, because using only a frontal lobe task, we don't know if we could use any other task and we would activate the same region. So, and that would lower the significance of our results. So we use a navigation task that is in virtual reality, and the person learns a route in the machine. Prior to that, they've practiced, and so they have an instruction: go to the bank, and they can move with a mouse inside the scanner. And what we see is that healthy control subjects, they show activations in the completely different regions of the brain, more in the parahippocampal regions of the temporal lobes. And the concussed athletes show very little activation when they're doing this task. So these two tasks have been used by us to diagnose whether there is still a deficit, and there's still not 100% recuperation from the concussion. We looked also at depression, because a lot of people complain of depression after a concussion. And so we looked at that. And as we can see, and when we submit the same task in the scanner, we see as the depression score increases, we see the activations lower. So the more the depression, the more severe the depression, the lower the activations in the regions. Now, for recovery, we retested the patients. So I'll give you some examples. These 14 subjects here, they show the typical activations that we see on pre-injury. So we tested them prior to the season beginning, and then we tested these 14 subjects within 72 hours of their concussion. So look at the patterns here compared to the absence of patterns here. And then 3 months later, 6 subjects were retested, and the activations came back. Okay? And the 7 remaining subjects whose symptoms did not improve, you can see at time 1, there was a lack of activation, and at time 2, the lack of activation is still present. And it's quantified over here on the histogram. Is that okay? Am I going too fast, or is it okay? Good. Okay. And we tested, of course, orthopedic injuries, because could it be that just having an injury of any kind would affect the patterns? And in fact, it doesn't. An orthopedic injury was scanned here, and we see the activation. And on recovery from the orthopedic injury, the activations remain the same. Now, treatment. We looked into treatment as well. We use repetitive transcranial magnetic stimulation. So it's the application of a magnetic field with a coil, as you see in the diagram here. And we apply this magnetic field to the region that we saw that is hypoactivated with functional MRI. So we stimulate that region to see if we can relieve the symptoms, you know. And so what we see is when we see an improvement of post-RTMS, we see an improvement in the symptoms. You see here post-concussive symptoms before RTMS was 48.1. Now it's down to 34.5, so there's an improvement. And the activations are improved, and we see the increase. So the increase is shown here from before treatment and after treatment. And whether it be with the verbal version of the task or the visual version of the task. And lastly, we tried looking at stimulation of the tongue. And this was interesting because the tongue is highly sensitive to touch. It has a lot of nerve endings, and it has a large cortical representation. And so, and it's a direct access to the brain. So there's a concept of neuroplasticity to stimulate reorganization. That's what we based our results on. And this is what the tongue stimulator looks like. You can control the time, etc. And this part goes on the tongue. And we combine it with physiotherapy to see if we can improve balance. It's ongoing. We haven't gotten the results that we were wishing for because we need to establish whether this stimulation alone, whether it can help improve the symptoms. So essentially, that's what I thought I would present to you, and then I'll answer your questions as best I can.
HeadCheck Health bridges gaps in concussion care through simple, powerful technology. Join organizations like the Canadian Football League, Trek Factory Racing, the Canadian Junior Hockey League, Eastern Washington University, and Volleyball Canada, who rely on HeadCheck to improve communication and optimize care. Visit headcheckhealth.com for more.